Good morning, everyone. My name is Maya Luria with TMC for Seniors, and today we're going to be talking about the art of minimally invasive hernia repair. I have Dr. Jason Nielson here with me. He is with TMCOne. He's a general surgeon, and he's going to share a little bit more about how you can get in touch with him if you are interested in this, and really talk to you about the technology behind hernia repair and how it works these days so that it's less invasive. So welcome, Dr. Nielson. How are you today?
I'm doing well. Thanks for having me. Just a little bit more background on me. So I grew up in Colorado in the Denver area. So I did med school at the University of Colorado. And then I actually did my surgery training at the Mayo Clinic in Minnesota. And now I did some additional training at Ohio State as well in critical care. And so I moved around a little bit, but finally found a good place down here in Arizona. So it's good to be here with you all. I'm going to talk to you a little about hernias. I'll talk just generally about what hernias are, why we worry about them, and why we treat them. And I'll show you what we're doing in terms of minimally invasive hernia repair, which has really changed how we do things quite a bit. So to go over that again, so I'll first start with what the complications are of hernias. And basically by that, what I mean is, why do we worry about hernias? Why do they concern us? What are the treatment options you have if you have a hernia? The minimally invasive repair in terms of what that entails. And I'll talk about what are the risks or complications associated with hernia repairs. And then I wanted to talk some about mesh, because that's in the news a lot lately. People may have heard about mesh or mesh lawsuits or concerns there. So I wanted to address that as well. So starting first with just generally what a hernia is, I describe it to my patients as a hole. So the tough tissue, which is called fascia in your abdominal wall, breaks down and opens up, and there's a hole there. Essentially, anytime we do anything that moves our belly, we stand up, we cough, we sneeze, we strain, that puts a lot of pressure on our abdomen. And so if you have a weakness or a hole, that can make stuff from the inside get pushed to the outside. So you can see here in this picture how there's a loop of intestine that's kind of pushing out from where it should be out into the abdominal wall. Now, there are a lot of different types of hernias that can happen. You can see this diagram and the diagram I had on the first slide. So common ones are around the diaphragm. Epigastric just kind of means above the belly button. Umbilical is a hernia in the belly button. Incisional, anytime we do surgery, afterwards, when that tissue heals, it's never as strong as it used to be. It's only about 80% as strong as it was before. And so if you have a natural weak spot, then over time, that may open up and turn into a hernia. And then the groin hernias are really common. There's actually 4 separate types of groin hernias. We just call them inguinal. A femoral hernia is kind of lumped in with that as well, but these are some of the common hernias, but there are actually many more than what I have just on this slide here. But about 10% of the population will develop a hernia during their lifetime. That actually is much higher in men. I think it's closer to 30%. And some studies I've seen as high as 40%. So it gets almost as high as a coin toss. About 1 million abdominal hernia repairs are done each year, and most of those are inguinal hernia repairs. So most of those are those groin repairs. Those are the most common type of the hernias. They're more common in men compared to women, so about 7 times more common. It's actually more common to be on the right side than the left side. That has to do with actually embryology. So when you're forming as a baby, the way things rotate, the right side closes later than the left, so there's more hernias on that side. The most common type of hernia is an indirect hernia, and that just has to do with where it comes in that inguinal region. There's a direct and indirect. It just depends on on which side of some blood vessels it is, essentially. About 14% of hernias are umbilical. Again, there's a natural weak spot there because when we're babies, the umbilical cord was right there. And then about 10% of the hernias that we fix are incisional, meaning we cause them by doing other types of surgery, or if a patient had trauma to the abdomen. The complications, the reason we worry about hernias, there's 2 main complications we worry about. One is called incarceration, which is just what it sounds like. It sounds like something's in jail, it's incarcerated. And the other one is strangulation. So you can imagine when a hernia comes through that weak spot, that hole in the fascia, if the intestine comes out and gets stuck and can't go back in, we call that incarcerated, like it's in jail. That can be dangerous because your intestine is like a big hose. So if it gets caught in a tight space, that can kink the hose, block the hose. And sometimes what happens is it gets kinked in there so tightly that it actually gets squeezed and it can cut the blood supply off to the intestine. We call that a strangulated hernia. So the intestine can start to die within the hernia, okay? But this is actually rare. Hernias are very common, but having a strangulation or incarceration is rare. So on here I put about 0 to 3%. It depends on what type of study you look at and what type of hernia you're talking about. Femoral hernia is a really tight space, so when stuff comes through there, it has a higher risk of strangulation or incarceration. And those type of hernias are actually more common in women than in men. So I have a lot of patients who will come to me and say, hey, I have this hernia. It doesn't cause any symptoms. It was just noticed by my primary care physician on an annual physical, but I didn't even know it was there until they pointed it out to me. Do I have to fix it? And basically the conversation I have with them is, well, if it's causing symptoms, I always recommend you get it fixed because that's something I can hopefully improve and help you with. If it's not causing symptoms, the risk of these complications is low. Now, and they certainly do happen, but more often than not, it won't happen. So if you want to observe the hernia, and we call it watchful waiting, I tell people that's reasonable if you want to do that. But these complications can be life-threatening and pretty severe, but it's also not subtle. If this happens, it's a big change. A hernia that's normally soft and not tender all of a sudden becomes hard, like a golf ball or baseball, usually very tender to the touch. If it used to go back in, it won't go back in anymore. And if your intestine is blocked in there, then if stuff can't go through, it tends to back up. So people get bloated or nauseous. So you have pretty obvious signs when that happens. And if that does happen, you just need to get to an emergency department as soon as possible because it can be time sensitive. We need to get that intestine out of there as soon as we can. So the treatment options you have, if you have a hernia, that first one, which I just described before, which I call watchful waiting, is just observing. I only recommend that if it's completely asymptomatic, or if maybe you're not a good candidate for surgery because of other health problems. There's the traditional open repair. So in open repair, when we say open surgery, we just mean bigger incisions. There's still a lot of open surgery that's done in the United States, and there's still good reasons and times to do it. So that just depends on the circumstances of your individual hernia. But whenever possible, we try to do a minimally invasive repair. Basically what a minimally invasive repair is, we try to do it through as small incisions as possible. So it just makes common sense, right? If I have smaller incisions, there's less trauma to the abdominal wall, my recovery and pain and things should be better, and it is better. And so as technology has become better, we have more tools that we can do things through smaller and smaller incisions. The two most common ones, you may have heard of laparoscopic surgery, which essentially is just a camera and instruments that we can insert through little incisions. And robotic is kind of the next level of that. I'll show you that and what that means a little bit in the presentation a little later. So this is an example of an open inguinal hernia right here. So these hernias, if you repair a hernia like this, typically for an open inguinal hernia repair in the groin, for me, you're looking at an incision probably about 4 inches or so in size. We go down, we do place a mesh. That's kind of what this looks kind of like your screen window kind of stuff here is the mesh. And then the skin and layers are closed back over that, obviously, after the procedure. So if you look at the studies in terms of when you do these open repairs, and what I've experienced as a surgeon is it's associated with more pain because you have a bigger incision. So oftentimes the recovery is a little more painful. The recovery takes a little bit longer as well compared to the smaller incisions. There is actually a slightly higher infection rate. Now, when I say that, the infection rates are low for both types, but it is slightly higher when you do open compared with the minimally invasive. It's a more cosmetic outcome because you have a bigger scar afterwards. And then, but actually some studies have shown that when you do it this way, there's actually less bowel injury or a chance of injuring the bowel. When you do an open inguinal repair, you often don't even see the intestine because you're in a completely different plane. So that makes sense why there would be less of those injuries. And actually some studies have shown that the chance of your hernia coming back might be lower if you get this type of repair. It depends on the type of hernia and your surgeon. With the new minimally invasive techniques, one of the important things is, so a repair like this open inguinal hernia repair, I can take a surgeon who's fresh out of their surgical training, and if they do this type of repair, their recurrence rate on that hernia will be generally below 4% and closer to 1% over time. If I take that same trainee and have them do a minimally invasive hernia repair, their recurrence rate will probably be closer to 10 to 12% until they get to about 250 cases. And then once they get to 250 cases, that number actually goes down and it mirrors the open. So what we see with the minimally invasive hernia is that you have to do a certain number of them until you get good enough at them that the recurrence rate is similar, because it's a little technically more difficult to do. So there's a learning curve there. So that's one of the things I always recommend when it comes to minimally invasive surgery. You want to make sure this is someone who does a lot of minimally invasive surgery so that you can get those similar results. Now, we talked about open hernia on the last slide, but this one actually is showing laparoscopic surgery. And basically what you can see here is the surgeon is holding an energy device. This is kind of a tissue sealer. And then he has a grasper, which lets him move tissue. And then the assistant is holding a camera. So there's little incisions made. And then essentially a tube, either metal or plastic, is inserted through that incision that keeps it open so we can put instruments in and out. If you've ever had one of those, graspers that you kind of squeeze and there's a claw on the end to kind of pick something up on the ground, that's kind of what laparoscopic surgery is. I call it straight stick surgery. So you can imagine how hard it would be if you had two of those to try to sew with. Okay. That's kind of what laparoscopic surgery is. We put in instruments that have very limited mobility, and the surgeons train quite hard and they get very good at using those. But it's difficult and it takes a lot of learning to do. But when you get those laparoscopic, those small incisions, there's less pain. We actually see lower infection rates. I think that's because mesh never touches the skin. We actually roll it up and can stick it right through one of those tubes. And people tend to recover much more quickly as well after those procedures. So a patient could come in for a hernia repair and end up with just 3 or 4 very small incisions, only about 1 centimeter or so in size, each incision. And then we have the next generation, which is the robotic. The advantages of the robot, people argue this a little bit, and surgeons argue this with each other a little bit. So it's interesting. So you can see here in the picture, this is the patient. These arms you see here are the robot, and this is the surgeon. So the surgeon is not even right next to the patient. The surgeon's sitting on a console. And when I do robotic surgery, I'll show you a video in a second of the latest robot model that's just coming out right now. Essentially, my hands are in the console, and whatever my hands do, the robot arms do. So, and the robot instruments move even better than a human wrist. So as before, I called it that straight stick surgery, which is really hard to sew. With the robot, now it's very easy to sew. In fact, I can take someone who's never used a robot before, give them about a 5-minute lesson, and they can start doing tasks on it because it moves just like your hands do. The surgeon, you can see he's kind of sticking his head in the console. It has excellent optics. When you look in there, it makes things 3D and it magnifies everything. So you can see much better than you can outside of the robot. There's actually certain modes in the robot that you can give the patient certain dyes and things that gives you almost x-ray vision. So you can identify structures. You can see how good the blood flow is to structures. Like if say you have to connect 2 pieces of intestine, you can make sure they have good blood flow before you do that. The surgeon, it can be really tough to do a laparoscopic surgery. So for example, when I do a laparoscopic surgery, I'm standing, and sometimes I'm holding onto an instrument and having to squeeze pretty tightly for 2 or 3 hours at a time. So you can imagine sometimes at the end of that, you're like, can hardly move your hand, or it's cramping because you've been squeezing for so long. And it does a number on our backs and necks and everything too. But now you can just be sitting at a console and barely moving your hands, and you can do a complex surgery. One of the surgeons I trained with, who is the best laparoscopic surgeon I've ever seen in my life, actually in part of his training, they did transatlantic surgery. So they had a patient in the United Kingdom. He was in Canada at that time. They had a patient, they got set up with a surgeon there. They placed the trocars, the ports, and then a person on a robotic console across the ocean could do the surgery on someone just by that connection. Yeah.
Wow.
So,
Yeah.
yeah.
Do we get his phone number?
Dr. His name's Dr. Kendrick. I'll send you that way if you're interested. But let me show you a couple videos. I hope these show up okay. They're kind of small because I crammed them on the one screen. So first, this is the Da Vinci system. That's the most common robotic platform used in the United States. Other ones are being developed, but this is widely adopted. Almost every hospital in this area has one of these. So let me show you what kind of fine work they can do. This first video is just, they're doing this on a grape. So you can see it's lighted, then you have the camera is in the center, and then those are the instruments. And just watch how fine a work you can do with the robot. So essentially they're gonna peel off a portion of the peel of the grape, and then they can sew it back on, and it almost looks like they've done nothing there. Again, you can see the surgeon in the background, his head's just in the console.
Wow.
So they can just very carefully manipulate tissues, and then you can do complex tasks like sewing, which is really hard, technically hard laparoscopically, but now the robot moves more like your own wrist. So you can see they took that whole piece of the pill off of there. They're taking another piece off. They're just peeling a grape, basically. There's another version of this video where they take pieces off and sew it back on, and it looks like they've hardly done anything to the grape.
The same they are using right now for the games when you have the goggles and start fighting or scaling.
It's actually very similar. So some of the newer robotic platforms, that's actually how they do it. So it's literally like you're wearing like a virtual reality headset, and then you have controllers just like someone with virtual reality. And so the platforms are getting smaller and more advanced. The Da Vinci Robot is actually pretty big. It takes up a big area in the operating room. So you have to have an operating room that's a good size for both that and the console. The other thing that is cool with the Da Vinci Robot is you can have more than one console. So say you're at a teaching hospital where you have residents, you can have the resident sitting at one console and the surgeon sitting at the console next to them. And so they can work together in concert. You can say, oh, I'm going to take over, and they just switch to them, and they can show you something and then go back to the resident. This is the most advanced robot system, the latest Da Vinci 5. Let me show you. This is kind of built as a sales video, I think, for physicians and hospitals, but it shows some of the technology. It's really cool. I think it's about 4 or 5 minutes. I'll show you this.
Intuitive Da Vinci 5 is our most advanced and integrated system ever. It's going to transform surgery for surgeons, care teams, and patients.
I've never seen anything like this before. Force feedback is the first of its kind technology. In preclinical trials, we're seeing up to 43% less force on tissue.
So with the current robot system, when you're moving those arms, you don't have any idea how much pressure you're putting on tissue. So if you see new surgeons using the robot, you'll see them like break stitch because those robot arms are strong. This latest system has haptic feedback. So when your arms are in the console and you move, you can tell how much pressure you're putting on tissue. They're becoming more and more
That
advanced.
translates to just for surgery for patients.
You can see that's a hand. That's the console that the surgeon's hand is. You can see them twisting.
But now with feedback, it does give you that extra sort of sense. It's not something I've seen with
Yeah. So the surgeon's hand is in that, and then the robot does whatever the surgeon's hands does.
Robotic surgery.
Yeah.
We're going to be able to control so many more things from the surgeon console now, which I think is really important.
It's really an immersive experience that gives you a next level of control that you didn't have previously.
The ergonomics, the ability for me to move the headset where my head goes in and move it exactly where I want it to be in a variety of different positions. I think that really is going to help elongate my career and make surgery more comfortable.
We are seeing Da Vinci 5 capabilities result in faster surgery, which translates to our customers' ability to do more surgeries in a year.
I think having the integrated new components will make the process of starting the case a lot more efficient.
The insufflator being in the vision tower is just a huge thing. We don't have multiple vendors within a tower. We literally can offer everything that we need for the patient under one umbrella.
I think it will make rooms more organized, so it helps with the staffing problem that we have, and also helps to reduce the cost.
Da Vinci 5 will help surgeons unlock new answers to surgical techniques and patient outcomes with unique and granular data. Da Vinci 5 connects more data than any other platform that I'm aware of, and allows physicians and their administrators to link them to patient outcomes.
This opens up an opportunity for years of innovation and years of things that are going to come next.
I can't wait for surgeons to get their hands on this.
Now we have a platform, an approach to do minimally invasive surgery that is beyond anything that we could have seen in those synchronizing movements. And that is what's giving us the magnification, the stability, dexterity, ergonomics, precision, all of which are key for us to be able to provide the highest quality minimally invasive surgery that we can to our patients.
We don't want to be behind in medicine. We need to be ahead, and that's what's really exciting about this next generation.
So like everything today, there's an app for that, right? So with Da Vinci, there's literally an app, and this new system is so advanced that it actually tracks the movements you make. So you can go and you can compare yourself to surgeons across the country. You can say, hey, for this hernia surgery, I can see how long are other surgeons taking to do this? And it will track all of my movements, and it can give me data and say, hey, you're doing this not very efficiently. If we change it this way, you can do this, the case faster.
It records all the procedure, and it keeps recording.
Yeah, so in this, in that latest platform, in fact, a lot of surgeons are already doing this. They're already recording all of their surgeries. And they're actually, it's really interesting. There's a Facebook group. It's called International Hernia Collaboration, where surgeons from around the world will post a case. Hey, I have a difficult hernia case. I'm not sure how best to approach this. And they'll post CT scans or whatever of their case. And they'll ask surgeons from around the world to help them. And world experts will chime in and say, hey, I would recommend you do this, this, and this. And then world experts will post videos of the cases they've done. So you can be in a third world country, anywhere that has internet access, basically. And you can, it's like you're taking a class from the best minimally invasive surgeon in the world. They can show you how to do a hernia or techniques that they do on the robot that make them more efficient. So there's that aspect of recording it and sharing it. And I think good surgeons like to record their work and go back and watch the case, and they can say, hey, I could have done this better. How can I do this more efficiently? Hey, maybe if we do this, that will take some time off the case, because less anesthesia time is better for the patient too. And then the app actually tracks how efficiently you're moving. And so it can give you feedback to say, hey, the way you're sewing, there's a better way to do it. Like you can do it with less movement, which will make it faster, and then less trauma on the tissues potentially too.
And what about the patient? I mean, you show us how the robot is working, but assume that it's connected with the anesthesia, levels of anesthesia or whatever.
Yeah, it doesn't affect anesthesia very much, to be honest. So it's the same anesthesia they would do for a laparoscopic case. Yeah. So anesthesia doesn't have any connectivity with the actual robot, other than they make sure the patient is relaxed just the same way they would for a laparoscopic procedure. Let's see, there we go. Okay, so I found this shirt online I thought was funny. Everything has a star rating today. It says hernia surgery, did not enjoy, would not recommend. So for most hernia surgeries today, especially the most common, which are inguinal, those are outpatient procedures. So you go home the same day. If it's done robotically, there's typically 3 or 4 little incisions, about 1 centimeter each. The most common configuration when they do it robotically is kind of 3 in a line right above the belly button. Some surgeries, if they're done minimally invasively, but it's more advanced, like you have a larger abdominal hernia and it's more complex, some of those still go home the same day, or they're just an overnight stay. They're not staying very long. Whereas when we do big open cases, sometimes patients were there for multiple days in the hospital. Afterwards, what I ask my patients to do, what we know about tissue healing is when things kind of get out to like 6 to 8 weeks, that's when things are healed about as strong as they're going to be. Your body continues to remodel a scar for quite some time, up to about a year after an injury. It's still doing some remodeling there. But from a strength standpoint, it's about as strong as it's going to be. So I just try to get people as close as possible to that 6 to 8 week mark before they do anything too strenuous. Usually I try to get them at least a month. So I just ask people not to lift much more than 20 pounds or do anything too strenuous for about a month after. I want them up walking and moving and being active. Just, it's more like if you put a lot of pressure on the hernia again before it's had time to heal, you don't want to, it could increase the chance of the hernia coming back. So you just want to give it some time to heal after the procedure. The risks of the actual surgery that I talk to people about, like if I'm in my office and we decided we're going to do a hernia repair, when I tell them, with any surgery, there's a risk of bleeding and infection. I'm going to make some cuts. So there's going to be some bleeding, and anytime you have a cut, it can get infected. That's very rare, but sometimes happens, but it's usually generally pretty easy to treat. The other risk I tell people, I just call it damage to surrounding structures. So by that, what I mean is I'm inside your belly, so in theory, I could hurt something while I'm in there. The chance of that happening is also very low, but it's possible anytime we go inside there. One of the most common complications I see after hernia repairs is something called a seroma. So I described the hernia kind of like a hole, but it's probably better described as a cave. So you have a cave, and during the surgery, we remove the contents of the cave and we block the entrance to the cave, okay? But the cave is still there. It's almost like an effectual empty space or an open space. And your body doesn't like that, so sometimes it fills it with fluid. That's called a seroma. So I'll have a patient come back and like, hey, I feel like my hernia is still here. There's this bulge. I'll say, yeah, well, it's the chance of it being a recurrent hernia that soon is virtually zero. It's almost always that seroma. And usually you don't have to do anything with that. You just wait 1 to 2 months and your body just reabsorbs it and it goes away. Sometimes it becomes more chronic and we might have to try to do some procedures to drain it or get rid of that fluid. But that's the most common thing I see. No matter how you fix a surgery, they can come back. How you fix a hernia, they can come back. Whether you do it open with or without mesh, they can come back and minimally invasively as well. So there's always that chance. And then I like to talk to people about mesh, like I told you at the beginning, because there's a lot of stuff out there on that. So this is what mesh looks like. This is a polypropylene mesh. Most of them are a polymer, so it's kind of like a medical grade plastic. It has those holes, it's woven together. That makes it flexible like a fabric, and it also lets your body incorporate into it kind of through those holes. The reason we use it is we used to do all these hernia repairs just with stitches, and we try to sew your tissues back together again. But what we've learned is when you do that, there's really high recurrence rates. So those hernias come back quite often when you do it that way. When you add the mesh, it adds strength. It kind of acts like a patch to the abdominal wall, and it decreases the chance of that hernia coming back again. So that's why we use the mesh, okay? When I talk to people about mesh, I usually talk about 3 risks of mesh in my mind. And the first risk is a mesh is a foreign body. So it's just like if you have a knee replacement, hip replacement, pacemaker, anything that gets implanted within you, if those devices get infected, which is rare, but if it happens, your body can clear an infection off its natural tissues. It has a really hard time clearing it off of a foreign body. So for example, I had an aunt who had a knee replacement that got infected. And they tried antibiotics, they tried all sorts of stuff, and eventually they had to go in and remove the knee, the joint, and kind of start all over again. The same thing can happen with mesh. If it gets infected because it's a foreign body, sometimes you can spare it with antibiotics, but sometimes the only way to get rid of it would be another surgery to go in and remove the mesh, okay, which can be a big deal if that happens to you. The meshes today are getting better. So they have bigger pores, and when the mesh kind of has those bigger open pores, actually we're able to save more of those with antibiotics, and less often do we have to actually go back in and remove the mesh. Okay. The second risk has to do with pain. So with any surgery I do, I tell people it's going to hurt. You're going to be sore after surgery for a while. But sometimes people develop chronic pain after surgery too. And that can happen after any surgery. to use another knee surgery. I had knee surgery on my left side, and it's still not quite the same. Like, it still hurts me. And that can be quite a spectrum in terms of sometimes you have chronic pain. It's like, this bothers me every now and then, to the other side where this hurts me every day. It just makes logical sense to me that when you have mesh in there, and the studies seem to support this, again, if you have something that's a foreign body, I think there's different scar tissue formation. I think the chance of that chronic pain is going to be higher. What I've experienced with my patients is most people with the mesh don't even know it's there. It just becomes part of them. Some people will say, if I really bend or twist or move, I can feel something. I feel like a pull or a tug, like something's there. But on the opposite extreme, sometimes people will have quite a bit of chronic pain with mesh. Surgeons debate this a little bit because there's kind of this debate as to whether the mesh itself causes that or if it's poor surgical technique. So some surgeons say, no, it's not the mesh, you're just putting it in incorrectly. Other surgeons are like, no, I think it's the mesh. I think they're both right. Obviously, if you use poor surgical technique, it's going to increase the chance of chronic pain. And I think the mesh in and of itself, having that foreign body, I think you have an increased risk. But in my experience, it's very well tolerated. Like I said, most people don't even know the mesh is there. Or if they do, the symptoms, like I said, might just be like, hey, if I really bend over, I feel like a pull, like something's there. The last thing with the mesh, and this is where a lot of mesh, I think mesh lawsuits and kind of horror stories on the internet you see, has to do with where you put the mesh. So if you put mesh on the inside of the belly, then it's in contact with intestines, with organs, okay? And so what can happen in that situation is, say intestines can stick to the mesh, which may or may not cause trouble. We call them adhesions, scar tissue when it sticks in there. Sometimes that causes trouble. Sometimes people live their whole life and don't even know about it. In some extreme examples, the mesh, the intestine can stick so densely to the mesh over time it erodes and creates a hole. We call that a fistula, which is a bad problem. So in this day and age, if we put mesh on the inside of the belly, we do one of two things. We use a special coated mesh that's designed to keep things from sticking to it. Or what we try to do, and this is where minimally invasive techniques are really helping, we try to put the mesh in a protected spot, somewhere where it's not actually in contact with the intestine. So with the robot, with the increased optics and the better mobility of instruments, a lot of times we're able to put the mesh like behind the muscles in the abdominal wall, so they're not actually inside the belly, and keep them out. The most common hernia repair, two types of hernia repairs I do are in the groin and then umbilical. And for both of those, I do what I call a pre-peritoneal repair, where basically the peritoneum is kind of like the sac that lines the inside of our belly. With the robot, I can make an incision in that sac and I can dissect it down, kind of like they were dissecting that peel off of the grape. I can then close the hernia, I can put mesh in, and I can reclose that peel, that peritoneum over it, so it doesn't actually touch the intestine. So minimally invasive surgery is making that better as well. And I'm not seeing nearly as much of that. With the mesh itself, sometimes how a hernia comes back when you have mesh in place, I think there's two things. One, sometimes you have something like a mesh failure. That's pretty rare. There were some older products that just weren't strong enough, and then maybe over time, stuff was able to break through. More often what we see is that the mesh like migrates or moves. That's kind of why I tell people to take it easy for that month or so after. Let it heal in well before you try to do too much, because if you too active and that moves or shifts, that could increase the chance of that hernia coming back. And then I put recurrence on here as well, because like I said, no matter how you fix it, even with mesh, there's a chance the hernia can come back. But with mesh, the chance of it coming back will be much lower than if you just do a primary, a suture or a stitch repair.
So all the mesh are made by plastic. It's a plastic one, right?
Yeah, so they're different materials. So the most common is polypropylene, and then polyester. Some are actually like some polyesters. There's other ones that are more synthetic, and there's some meshes that are even absorbable, or what we call biologic. So it's kind of a biologic tissue. So there's a lot of different materials actually that the meshes are made of.
Yeah, I was thinking use some kind of natural fibers, like plant fibers, I don't know, agave fiber, something like that. More natural, because to have plastic inside you, I think that's all the problem comes from that. Those are my thoughts.
No, it's a great question, because They came out with some more absorbable meshes, and for me as a surgeon, I think I was really excited about it because I thought, hey, I can fix the hernia, they can have a decreased recurrence, but then that mesh eventually goes away, so I can maybe avoid some of the complications of the mesh. The one I know that's been the most studied recently is a mesh that's called Phasix, and it's one that kind of goes away with time. So it just disappears. It kind of acts as a scaffold for your body to heal, and then it goes away. The early data on that, if you follow hernias out to about 5 years or so, the recurrence rate was just the same between that and the permanent mesh, like the permanent plastic. And so we were all really excited. We're like, hey, this is the future. But then more long-term data comes out, and it seems like that hernia recurrence rate starts going up quite a bit after that. So once it disappears, it goes up. So they're continuing to work and try to refine and find the best material. So I think that will continue to change over time. So in conclusion, hernias are very common. At least 10% of the population will have one. I think that number is actually low. In men, it's probably closer to 30% or higher. Most often they're not dangerous, but there are those two dangerous complications, the incarceration and strangulation, which are rare, but if they happen, it can be even life-threatening. The treatment options that we have for them include observation if it's asymptomatic versus an open or a minimally invasive repair. And then the minimally invasive surgery is associated with less pain, lower infection rates, and people just tend to recover better recovery. And then when it comes to mesh helps reduce the recurrence rate. That's the main reason we use it. It's generally safe, and in my experience, in the vast majority of cases, very well tolerated, but it does have some risks that you need to be aware of as well. Okay. So that's my office address. I actually was hired more to work at the new TMC facility off the Houghton, so my office is out there. And that's my phone number. If you wanted to see me or had a hernia, that's my office phone, so you can call there to get an appointment. And thank you. I'd be happy to take any questions or turn it back over.
Thank you so much, Dr. Nielson. So I have to say, very fascinating to see the Da Vinci peeling the grape. You know, that's pretty wild to see how precise it is in its movements. So, but I do have a couple of questions. What is the criteria that you consider when deciding on a surgical approach to use for a patient? Is it always now, for instance, if you've got a Da Vinci available, is that the way you always go, or how do you make that determination?
Yeah, that's a great question. So I always try to do minimally invasive when I can. For me, in this day, I have done a lot of laparoscopic before, but I've transitioned mostly to Da Vinci just because of the advantages it has. But that's not always the best repair for a patient. For example, I had a patient the other day who had a previous minimally invasive repair on a groin hernia, and now they had a recurrence of it. And so some surgeons will go back in the same way they'll go back in minimally invasively again. But when you do that, you run into all the scar tissue and things from the prior surgery. So it can be quite difficult and can increase the chance of injuring structures around there. So in that patient, I'm actually going to do an open repair. I'm going to come from the other side because someone's already kind of burned that in that minimally invasive bridge, if that makes sense. So for me, it has to do with what type of hernia is, how complex the hernia is, if it's a recurrent hernia. Sometimes if a patient has had multiple prior abdominal surgeries, trying to go back in minimally invasive, you just run into too much scar tissue. So you might be looking at more of an open procedure in that setting. I try to do least invasive, but also what's the most safe for the patient. So it's kind of a case-by-case basis.
Sure, okay. And what information or what key information should patients be aware of prior to surgery, just to help with the most success post-op?
Yeah. What I see happen, I call it the hernia spiral, and that's a total made-up term by myself, but I see a lot of patients who come in for a hernia surgery, and they get a hernia repaired under non-ideal conditions. And then if you get it repaired under non-ideal conditions, almost certainly you'll have a complication or the hernia will come back again. And then you're trying to fix a hernia again, and it's even harder because there's scar tissue, and those same conditions might still be there. And so I see people, it's kind of like spiraling, almost like a flush down the toilet, just issue after issue. And so as much as possible, I try to, at the beginning, address any issues that might cause us to get on that spiral. So the most common issues, things that we can change that help, if a patient is smoking, it increases the chance of virtually every complication they can have. So an infection, poor healing, recurrence is all going to go up. So if I have a patient who's smoking, we try to work on stopping smoking. If you're overweight, if your BMI, if you're familiar with that term, if your BMI is above 30, and really the transition point seems to be when it gets to 35, then the chance of your hernia coming back becomes way higher. So if I have a patient who has a hernia that is causing some symptoms, but they're still able to kind of go about life, and their BMI is above 35, as much as possible, I try to get work on some weight loss to get them down below that, just to try to avoid those complications. So I'd say there's some health factors that we might need to work on a little bit to try to give you a better outcome for your hernia repair.
Okay, that sounds great. Now, you mentioned, I know you're at TMC Rincon.
Yeah.
And so obviously we have a Da Vinci there.
We have a Da Vinci, it's an XI. So the one that I showed you, the Da Vinci 5, that one, it's not fully distributed yet. It's kind of in like test hospitals right now, but it's done so well, I think they're going to start distributing it. So the most advanced one that most hospitals have right now is the XI, and that's what we have at Rincon.
We are
Okay.
And we're getting to 5 here at Maine, 5 soon here at Maine. Yeah, so they're starting to roll out across the country more, that one I showed you in the video.
Great. Now, so I do want to put up, in case somebody is interested for an appointment, the phone number is 520-420-2280. Can you just tell us where your office is located?
Yeah, so if you go to that TMC Rincon Health Campus, there's 3 buildings. There's the hospital, there's an outpatient surgery center, and then there's a building that has the urgent care within it. That's where my office is. It's on the 2nd floor of that building.
Okay, and that's at Houghton and Drexel, correct?
Houghton and Drexel, correct.
Yes, okay, great. Thank you so much for being here, Dr. Nielson. I'm going to wrap up with our online audience, and I'll turn it over for any questions in person. Thanks again for being here.
Yep.
Thank you so much. I look forward to seeing everybody again this afternoon. We've got 2 presentations today. Today at 3 o'clock, we'll be doing Balancing on Air, Peripheral Neuropathy, and Fall Risk. That is today, Wednesday, September 25th at 3 p.m. We will have Fran West here with us from the Center for Neurosciences for that talk. In addition, I'm looking forward to next week. We have a couple of talks that I just want to share as well, especially for men's health. We've got Real Talk about prostate health on Tuesday, October 1st at 3 p.m. And we also have the nuts and bolts of men's pelvic floor on Wednesday, October 2nd at 2 p.m. If you are interested in either of these talks, please give us a call in the office. We'd be happy to get you registered. The phone number is 520-324-1960. We look forward to seeing you soon. Thank you.